Welcome to Decoding DX. We're a group of fourth-year medical students with a passion for education and patient care.
This episode of Decoding DX is for educational purposes only and should not be used as medical advice. Please consult your healthcare provider for any medical needs.
The opinions expressed represents those of the participants and are not of our affiliated institutions.
Thank you for joining us on Decoding DX. We keep learning so much through this experience, and we're so glad that you're learning alongside with us. Now, let's get to the episode.
All right, welcome everybody to another episode of 10 Clinical Minutes. This is going to start off a series of OB-related 10 CMs that I hope will be of service to you on your OB rotations, and then also in future OB practices. So this one, we're just going to talk about prenatal care visits. So first and foremost, you have your estimated due date. A quick calculation for that is to take the LMP, subtract 3 months, add 7 days, and then give it a year. So for example, if mother's last LMP was on 6/1 of 2020, you would subtract 3 months, which would be 3/1 of 2020. You'd add 7 days, which would be 3/8 of 2020, and you give it a year, which would be 3/8 of 2021. You can also use a pregnancy wheel. This is an example right here of what one of those looks like. Often you'll find those on labor and delivery floors. You can also look them up on MD Calc or on any website. And then when you're doing the estimated due date, you really want to confirm with ultrasound. And so if the ultrasound's done between 0 and 8 weeks, it needs to be within 5 days of the LMP, between 9 weeks and 13 days within 7 days, 7 days for 14 to 15, 6, and then 16 to 21, 10 days, 22 to 27, 14 days, and greater than 28 weeks, 21 days. And what this tells you is if the LMP and the ultrasound differ by greater than any of these numbers, either in the positive or the negative direction, you would redate the expected due date based off of the ultrasound finding. As is clearly evidence here, the earlier you can do an ultrasound, the more accurate it is, with the CRL within the first 14 weeks of pregnancy being the most accurate. But as you move on in the pregnancy, you can still get decently accurate within 1 to 3 weeks estimate, depending on what part of the pregnancy you obtain the ultrasound in. But that involves these 4 different measurements, which is a slightly more involved ultrasound and takes a little bit more time to do. So CRL, first 14 weeks would be the ideal. And beyond that, if you're outside of these dating windows, then you redate the pregnancy. So what do you do when a mom comes in while you're going to do your prenatal history and physical? The history is largely going to get at how they've been feeling, have they felt the baby move, have they had any vaginal bleeding, have they had any loss of fluid, have they had any contractions. And then you might ask for symptoms based on risk factors. So these are just some of the symptoms for preeclampsia, pre-E that you might need to be concerned about. On the physical exam, you're going to do vitals, weight gain, heart rate, fundal height after 20 weeks. Before that, it's not really estimate. After that, it should basically corroborate to the weeks, 20 weeks, 20 centimeters, 30 weeks, 30 centimeters. That's from the pubic to the top of the fundal height. And then also you're going to evaluate CV, pulmonary features, and that's including edema. And then you have your follow-up, which we'll talk about a little bit more in the next slide. So initial testing, you're going to order an OB panel at a lot of institutions. You just type in OB panel and it comes up. But these are the different things that are on it: your CBC and your blood type, your antibody screen for RH immunization, and then a test for some infectious diseases, hepatitis B, rubella, syphilis, HIV, gonorrhea and chlamydia, and tuberculosis. If a PAP is indicated, you would obtain it, and you also do your analysis and culture. And that's to check for proteinuria at a baseline, but then also to assess for asymptomatic bacteria, because this is one of the few indications for treating asymptomatic bacteria, because the undiagnosed UTIs can lead to preterm labor, so that's why you treat during pregnancy. And as mentioned previously, depending on how many weeks gestation the mom is, that's going to determine how often you will see them again. So if it's less than 26 weeks, you go every 4, 26 to 32 every 3, 32 to 36 every 2, and then greater than 36 every 1. And one thing that moms will often joke about is that the more they're seeing the doctor, the sooner they're going to be to having a baby, and so they get pretty excited about that. So this another portion of the prenatal visit is counseling. On the left, you see just a kind of a wide variety of topics that you can counsel on. By no means is this an all-inclusive list. There are many things that you could talk about. We're highlighting just a few here. One is weight gain. It's a common question. There is recommended weight gain. The estimated caloric increase that a mom needs is not an extra meal a day for the baby, more like an extra PB&J, right around like 300 calories or so. So this little table here shows you what the recommended weight gain is based off of the initial pregnancy BMI. Another thing moms often have a question about is it safe to do physical activity? The answer is yes. Generally, a good rule of thumb is if a patient is already running, they can keep running. If they're already biking, they can keep biking. But you want to avoid high impact activities, as that can cause some adverse complications, some bleeding, etc. But generally speaking, the activities that a woman is doing prior to pregnancy, she can continue during pregnancy. And if a woman desires to start running during pregnancy, you can do that. Just don't start off doing marathons. Maybe start off with a shorter distance and work your way up, just like you would at any other point in a person's life. Also, we want to talk about what safe over-the-counter meds are. This is a classification and indications for medications in pregnancy. A would be no fetal risk in controlled studies. X is contraindicated, and then a variety in between. It's just helpful to know. You can look this up if you need it. So whenever you see a medication, you see it's a letter grade, you know what that means based on the pregnancy. And then the last one we'll kind of touch on is the interpersonal or intimate partner violence. There's a series of questions you can ask at multiple different points during pregnancy to screen for this. Women are at more risk of interpersonal partner violence and intimate partner violence during the pregnancy. And part of that, or one thought for that, is that it's a result of the change in family dynamics or in household dynamics that occur with an upcoming pregnancy. So then we move on and we start talking a little bit about genetic screening. And in that genetic screening, we are screening for Mendelian disorders. So those would be autosomal dominant, autosomal recessive, or carrier screenings, and X-linked. And also chromosomal abnormalities, which there are a couple of different ways to go at it. A more old-fashioned version is doing a sequential screen, which is a triple and then plus a quad, or a CBS or amniocentesis. Those are done less commonly now than they were in the past. And then the new kid on the block is a cell-free fetal DNA, which is done earlier than the triple and quad, and we'll kind of show where that's at on the upcoming slide. And it actually is more sensitive, has a better negative predictive value and a better positive predictive value. The mechanics of that test are pretty cool. It'd be worth looking up just so you can explain that to patients. But as you can see here with these two tables, the maternal age in years definitely changes the positive predictive value of a test. Doesn't have much effect on the negative predictive value. And so if you have a positive, this is a quadruple screening, a positive test in a 20-year-old, the likelihood of that actually indicating trisomy 21 or another inequality event is pretty low. It's more likely to be an abnormal test than it is to be an abnormal finding. And this low positive predictive values by these were commonly followed up with either CVS or amniocentesis to confirm for the diagnostic testing. With the cell-free fetal DNA, you really see the same pattern at 20, 68% positive predictive value, which is much better than the quadruple screen, but still not great. And then as you get, as pregnancy gets older and more advanced and it's at higher risk, that positive predictive value increases because the incidence and prevalence is increasing. And that's shown here in the second column. And there's highlighting just negative and the positive predictive values. Another portion of the prenatal care is doing immunizations. You have some that are indicated: influenza, Tdap, HIV, HPV, pneumococcal, and then meningococcal if indicated for other factors. Then you have contraindicated ones, which are the live vaccines, MMR, varicella. Then HPV is a little controversial, currently not recommended and not advised during pregnancy. These are just some sampled interventions you could do based on previous pregnancies. If someone has a history of preterm deliveries, you can do progesterone in the second trimester to try and help them continue to carry the pregnancy. History of preeclampsia, aspirin 81 milligrams. You can see more of that in an upcoming video we'll have on preeclampsia and hypertensive disorders of pregnancy. Gestational diabetes, you would do earlier oral glucose tolerance test screening, and you may even repeat it during the pregnancy to try and catch it earlier. And then a mid-trimester loss previously with cervical insufficiency and the cervix less than 2.5 centimeters measured on ultrasound, you consider cerclage. At that point, you're likely referring to maternal fetal medicine and high-risk OB. And then in the current pregnancy, if they have hypertension, sometimes you don't have to treat it. If you do have to treat it, these are medications that are safe to use in pregnancy and indicated. Gestational diabetes, first line is diet, physical activity. Then you can do metformin. Many of the diabetic medications either have not been tested in pregnancy or have been shown to have harm in pregnancy. And then asymptomatic bacteria, you can use any of these agents to treat it, and is one of the rare indications for treating asymptomatic bacteria. So kind of just walking through what you do on these prenatal visits based on the time of the pregnancy. I'm not going to talk through everything on this table. Feel free to pause the video after we reveal it all and take a look at it for you, take a screenshot, do whatever you like with it. So in the initial, we're going to get some of the lab work we talked about, do a dating ultrasound. If it's a season, do influenza, do some of the vaccinations, and start the process of counseling. Between 10 and 14 weeks is when you do that cell-free fetal DNA, which is earlier than the quad screening. The nuchal translucency would be part of the old triple screening. And then that'd also be when you do chorionic villus sampling, if you're going to do it. Around this time, you could start talking about sexual physical activity, as well as seatbelt use during pregnancy. Definitely use seatbelts, and you can continue to be sexually and physically active. Between 15 and 22 would be when the quad screening typically was performed. You do a growth ultrasound to assess for anatomic defects, and it's when amniocentesis used to be performed. But that, again, as I've said, is a increasingly rare procedure. Between 24 and 28 is when you do that first round of oral glucose tolerance testing, unless you have an indication to do it earlier. Repeat some of the labs. If at high risk, you repeat some of the STI and syphilis screening. And you're grabbing this UA of culture each time just for the asymptomatic bacteria that we talked about, as well as screening for proteinuria. This would be when you do RhoGAM if a mom was Rh negative. And you'd also do Tdap to begin to prepare her antibodies to pass through the placenta to the baby to protect the baby from pertussis following delivery. Between 35 and 37, you do GBS. That test is sensitive for about 5 weeks after its completion. If a prior pregnancy has been GBS positive, then you don't need to repeat it because you just treat it as if it's going to be GBS positive. You can start to assess for fetal positioning. You can start counseling on what changes are going to happen when an infant comes. And then the last one, between 37 and 48, you're doing cervical checks, changes after delivery, and continue to fetal positioning and some pre-counseling before the delivery, as well as checking vital, blood pressure, etc. Go ahead and pause the video if you need to. So then we have fetal well-being assessments and evaluations, fetal movement, non-stress testing, contraction stress testing, biophysical profiles, and Doppler ultrasonography of the umbilical artery, which is a fun phrase to say. So fetal movement, a normal sign is if the mom reports it. And the follow-up testing is if she doesn't report it, to pause, count, wait, and see if she's feeling the baby move. For non-stress tests, you add a tachometer on, you do some fetal heart tracing. We'll have a video on that as well. That's coming out here in the next couple of weeks. And if it's, you're looking for 2 accelerations in 20 minutes. If the child is not responding, you can do some acoustic stimulation. Reasons why you might not have accelerations could include maternal medications. Could also include the fetal sleep cycle, which can take up to an hour. So sometimes you have to monitor for quite a long time to see if you have these accelerations present or not. And then you have the definitions there underneath. More about accelerations and how to read a fetal heart strip in that other video that we're putting together. Then we have contraction stress testing, where you administer oxytocin, and then you see if any late or variable D cells. If you do have late or variables with contraction stress testing and you're concerned, you could omit or you could repeat the testing in 24 hours to see if you see similar symptoms. Then we have the biophysical profile, and this is one that has a little bit of predictive value. You're looking for a score greater than 8 or equal to 8 that includes this AFI pocket greater than 2 centimeters deep. If you have a biophysical profile test that does not have an AFI amniotic fluid index pocket greater than 2 centimeters deep, then you're concerned about oligohydramnios. In that indication, you begin considering delivery and considering interventions that you need to make in light of that, as well as additional monitoring. So even if you have a BPP that's greater than 8, but you have an oligohydramnios, that is not a normal BPP, and you need to do further workup. However, if you have 8 of the 10, 0 to 2 for each of these on those, but you have that AFI pocket, then that's a normal test. And generally speaking, that means that you're good to go for a week. So these will often be repeated twice weekly so that you kind of keep a rolling circuit with a low risk of fetal demise in the 0.4 to 0.6 per thousand bursts range for that 1 week predictive value. If your score is less than that, then you need to look further and see if there's something going on in the pregnancy that requires an intervention. That would definitely be an MFM consult, would definitely be high risk OB, would definitely warrant further evaluation and workup. And then lastly, Doppler ultrasonography, you're looking for normal anterograde flow. If you don't have that, it indicates that your pressure in your placenta is off, which could be a sign of preeclampsia, it could be a sign of uteroplacental insufficiency, and is definitely a sign of concern that needs further evaluation for whether or not delivery is indicated, and you need to repeat that test. These are just a list of complicating conditions that can show up during a normal prenatal period, things that can occur, things that you need to be on the alert for. I'll draw special attention to the psychiatric. Often those are missed: depression, anxiety, psychosis. first two more common, and those continue after the postpartum period, or continue throughout the postpartum period. The rest of them, our medical brains tend to think of more commonly, and also tend to be reported, but those significantly affect patient lives, significantly affect children and newborns. We need to be aware of as providers. Lastly, here are the references. A special thanks to the VCRIST and Wesley Family Medicine residency programs for providing some of the skeleton for prenatal visits based on the practice that they have and obtained through discussions with them while on rotation. So then the rest of these, you can look them up. If you have any questions, please contact us, info@decodingdx.com, or leave a comment here on the slides. Thanks so much. Have a great day.